what are some training or support that you believe that we can give out?
There is so much, and I want to give a big shout out to the Opioid Response Network, the ORN, okay? Amazing. There is so much information for NPs, PAs, physicians, medical students, all of us to hit the ground running. As providers, as medical students, nurses, PAs, physicians, we have to love and care for our patients. And those who have substance use disorders are often shunned by their family members, their friends. They don't have a support network. We are it for a lot of people. So when you encounter persons with substance use disorders, kindness and compassion is the most important thing.
Hello, everyone, and welcome to Transformed Minds. This is the podcast where we explore the real world intersection of mental health, addiction, and transformative care. I'm your host, Dr. Wusu. Most people call me Dr. O. You could call me that too, that's fine. So, in each episode, we take a very thoughtful and practical, evidence informed look at how we can improve psychiatric and addiction care. From clinical settings to community spaces, we hope to bring the best care to the people that we serve. So today, it's actually going to be an Expect RX episode, and I'm so glad that you're here with us. So if you're new here, welcome, and here's the vibe. When we do the host RX, it's mostly just me and you breaking down research, sharing what actually matters for you, including mine as well. And when we do the expert RX, we bring in brilliant minds from the field, like our brilliant doctor that we have here today. And in the field, it could be a clinician, a researcher, physician, scientist, change makers. It could be an array of experts that we have. And the last segments that we tend to have are also called Lived RX. And this is where we share very real life stories that come in, and the guests are people who have lived these experiences, they've survived it, and they're helping reshape the system. And we believe they are the core of the care that we provide because they have lived these experiences. So today we have the beautiful, most amazing, someone that has been a mentor to me and I appreciate so much, Dr. Bowe Adina. So we're going to give it a club for her. She is the amazing assistant professor of internal medicine, psychiatry and addiction medicine at West Virginia University, CAMC. If you do not know what all of this means, it just means she's an expert in all these fields, not just psychiatry, not just internal medicine, but addiction psychiatry and addiction medicine. So she's the best person to have here today. She's completed her medical school at the University of the West Indies. She completed her residency in internal medicine and psychiatry, double board at the West Virginia University, and her fellowship in addiction psychiatry at Yale University. She's currently the director of the West Virginia Comprehensive Opioid Addiction Treatment Program at the Charleston Division. She's also the Associate Program Director of Internal Medicine and Psychiatry Residency Program at West Virginia Charleston Division. She has numerous professional affiliations. She is currently the Medical Director of West Virginia Health Right, which provides more than 45,000 medically underserved, uninsured, and underinsured adults with free comprehensive care. If you didn't hear that, I'm going to say that one more time. She is currently the medical director of West Virginia Health Right, and it's providing not just any care, but it provides over 45,000 medically underserved, uninsured, and underinsured adults with free comprehensive care. Free comprehensive care. And you know, this is so important to what we do. She is on the board of directors for REACH through the Yale University Essenza Initiative, recognized and elevated racial disparity in addiction through culturally informed healthcare. She's actively involved in the American Psychiatry Association and the American Association of Addiction Psychiatry, and is on the board of directors as chair of Health Access Committee for the AAAP. Dr. Bowe has special interest in treating patients with comorbid medical and psychiatric illnesses in rural settings. Dr. Bowe originates from Nassau, Bahamas. Did I say that right? Okay, because I'm always like, I don't want to butcher the name, but that's where she's from. And she enjoys being outdoors in her spare time, Her motto is, although we all look different, inside we feel the same. Please help me welcome the amazing, my mentor, and the most wonderful Dr. Bowe.
Th- Thank you for letting me be here, Dr. O. I really admire and respect your work.
Oh my God, I am so excited to have you. And I am literally, I don't know if you guys can tell, I adore her. So it makes me excited to have her here. So we're going to do a brief overview of our problem today. So today, what we're tackling is the issue of access to opioid use disorder treatment. It's been a long going crisis that we're battling in our field. Despite the effectiveness of medications like buprenorphine, methadone, many people still face major barriers to this. And one thing that I always say is even the methadone management feels incarceral, the way that care and management is sometimes provided. So today we're going to explore a very landmark study on how to overcome those barriers. And as you've heard, if you didn't hear anything from the beautiful biography I read of Dr. Bowe, it just shows that she's an expert in cultural barriers and creating and giving free access to care to these people. Today, we're going to talk about the study titled Improving Access to Evidence Based Medical Treatment for Opioid Use Disorder, Strategies to Address Key Barriers Within the Treatment System. So, this research basically outlines persistent challenges in delivering medication for opioid use disorders. This includes a stigma that it comes with, shortages that we may face, regulatory barriers and hurdles, limited integration to like general health care, because sometimes addiction care or even psychiatric care is seen very differently from medical care, and that could be a huge barrier. It also proposes like a very practical and system level strategies to close these gaps and improve access to life-saving care. So, in the study, a very quick synopsis. This article, as I already mentioned, it's outlining systematic and structural barriers. And it focuses on access to evidence based treatment like buprenorphine, methadone, and naltrexone. What it does is also highlights why it's underutilized. And despite how we have very well documented evidence based like literature out there saying this medication works, yet we're not prescribing them as we're supposed to. So, what are some of the barriers? The barriers that the study found include workforce limitations. So, it's not enough waivered providers that are providing them. There's also a stigma within both the clinicians and the public. And there's regulatory constraints that comes with it. There's fragmented care systems, limited integration of addiction into general medicine settings, as we've already said. And they propose a few strategies, expanding training. So if you're here, I am implementing one of those strategies is expanding the training and the knowledge to all healthcare providers. Here we are. You're a curious mind, you want to learn. This is part of expanding that training for healthcare providers. Policy reforms, increasing coordinative care of mental health, addiction, and primary care, and leveraging telehealth and low threshold treatment programs. So today, Dr. Bowie's here to help us dissect the study a little bit more with her expertise. So we have a few questions for Dr. Bowie that we're going to start with. So the first question that we have, Dr. Bowie, but before that, if you have anything else you want to say before we get into all these questions.
Not at this time.
So the first question is we see that the study is like emphasizing study limitation, workforce limitations. From your experience, how does like provider availability affect a timely access to what we call MOUDs, which is the medication for opioid use disorders?
Okay, I love that question. And I'm sitting in West Virginia, we see a lot of those types of problems, right? Because when you don't have enough providers who can diagnose and address the problems, then you don't have enough people who can care for our patients. For example, even in our area in Charleston, we have maybe 4 or 5 doctors who are actually board certified in addiction medicine or addiction psychiatry who can address concerns. So then you would find that primary care providers and even in general, many psychiatrists don't have the proper training. So when patients go there, they feel overwhelmed and they are often referred out. And unfortunately, if you don't have enough providers, wait lists is very long. So you'd find that people have 2, 3, 4 weeks, even a month wait list to get into substance use disorder treatment which is horrible because when someone has a need for treatment, access to treatment, it's critical to get them in right away while they're ready, while they're prepared, when they're ready to make that next step. Waiting 2, 3 weeks is too late for most people.
Yeah, that's interesting. For a place like Charleston, someone would think in the United States we have all the access to care. But from the stats that you just gave us, what's the population of Charleston to have five specialists that are actually providing care to all these individuals?
So we know we provide care to at least 50,000 people in Charleston, and then you have all the surrounding communities. But the problem again is being able to attract people and providers to live and work in a rural setting. And then when you have those providers who work and live in a rural setting, then you have to think about terms of reimbursement, right? Because unfortunately, for substance use disorder treatment, many of our patients fortunately have Medicaid, but unfortunately the reimbursement is very low. And so you would find a lot of providers are not attracted to studying the type of medicine, to even provide that type of care, because if you go into private practice, many times you can't pay your bills. So one of the things I know at the state level and the federal level, we try to advocate for like for example, loan repayment for physicians who work in rural settings who treat people with substance use disorders. Also, we try to advocate a lot for just larger reimbursements and ongoing reimbursements, especially when it comes to telemedicine. So places like Charleston, West Virginia, and other Appalachia, we call it geographically challenged, right? So your providers who live in cities, but most people live in rural outskirts, and there's lack of transportation. So not only do you have a lack of provider, you have a lack of ways to get there to actually get to see a provider. And fortunately, telemedicine has really opened up the field.
And we see that from the study, telemedicine is one of the proposals that they are proposing to help. That's one of the strategies because then people from even far, people that can make their appointments, can call into tele health appointments. But I have a question for you. When it comes to treating these disorders, especially opioid use, right? And we have methadone. Methadone is controlled. So, how are the regulatory barriers when it comes to prescribing these, especially in the telehealth setting, where they're at least in where I'm at in New York, we have policies where the patient has to show up or the person has to come in one of the sessions, right? So, how is all of that and the barriers to care?
So that's a huge barrier to care because, first of all, methadone is so highly regulated that very few people can access that care. In most methadone programs, you're federally funded and you require patients to come in on a daily basis for at least the first 90 days, except over weekends when you get take home. So imagine if you live 1.5 to 2 hours away and have to make that long travel, it's almost impossible. So the regulatory barriers include providers being able to provide that care and being limited to daily care. And in fact, many places do not offer telemedicine that are methadone treatment centers, right? Because of those barriers. And so many states now are trying to urge the federal government and state government to kind of adjust those laws and make it more flexible. And there are now ongoing studies to see and test the efficacy of that treatment if people are allowed to take home their medications as opposed to having to come every day.
Well, we will hope and pray that these regulations actually come in so people have more access to the medications, especially when we know like the different transtheoretical model and the different stages of change. So when someone is really ready to, get treatment, it's important that they have that access and they're getting the most efficacious treatment out there. So the other thing we see in the article is that they highlight stigma as a very major barrier, even amongst providers. What is your experience and what do you think are the most common misconceptions?
Well, so we certainly experience a lot of stigma in the medical field and often amongst providers. Fortunately, there are many, I guess, opportunities now for providers to have more access to information, and that really reduces big stigma. The stigma comes from these thoughts that, hey, the patient really wants to get better, they would. It comes from having limited access to the education the provider needs to treat the patient. And the stigma comes from just being a social outside social influence, like is your fault. It's the patient's fault. It's not the provider's fault. But a lot of the stigma also comes from providers feeling ill-equipped and underprepared to take care of the patient. And so then they tend to see those patients as more challenging patients, patients who don't get better. When in fact, evidence-based medicine says people who engage in treatment for substance use disorders had the exact same success rate as those for hypertension and diabetes. Isn't that amazing?
That is amazing. That is why studies are important and the dissemination of those studies, right? Because we have these studies, but a lot of even providers do not know, they're not aware of all this information out there. So if we know that treating someone with a substance use with an efficacious medication, a medication that has been proven by multiple studies to be effective, right? If we're using it for these people and we're getting the same effect as treating someone with diabetes, why won't you use it? Right.
That's right.
So
Gotta get the word out there. Treatment is connected. Treatment work.
have to get the word out there. So I'm gonna give a shout out to the NIH and NIDA for sponsoring this project that I can put this information out there, invite experts like yourself to come and teach us, right? Teach us more than what we know. And even if it's one thing that someone gets out of this, it's very important. What are some like training or support that you believe that we can give out? Primary care providers, all these providers, like what can we do for them so they can get
Boy, there is so much, and I want to give a big shout out to the Opioid Response Network, the ORN. Okay, amazing. There is so much information for NPs, PAs, physicians, medical students, all of us to hit the ground running. And a lot of the training are done from experts in the field at different levels. And man, they break it down so easy. You can understand. They also link you with mentors to the ORN. They can link you with information to pharmacies, pharmacists. It's just so much available and it's all accessible. And guess what? Is it free? It's free. So a big shout out. The other thing is accrediting boards have also mandated throughout states that hospitals require their physicians to get adequate training in these areas. So, for example, you can't be a physician these days and not have adequate training, at least an 8-hour training inside how to treat opioid use disorders or substance use disorders. The thing is, the 8-hour training doesn't always make people more comfortable doing it, even though it provides the information. So, we're so happy we have entities like Triple AP and the ORN to support our providers. And we are always looking for people to help. We want people to come to us with questions. We want them to come to our webinars. Just get the help you need because together we can tackle this.
Yes, and if you want more information, I will put all of the things that Dr. Bowe have mentioned, I will put them in the links and you could really get to them. And I would tell you these are very effective resources to use. I have used the Opioid Response Network as a trainee because in my community, we don't really have enough addiction specialists and the resources. So I used one, Opioid Response Station at Columbia, who has been very helpful, even in my research and everything that I want to do. So if you're out there, reach out to them. You can Google it, use the link below. You can do all of those things. The next question I have for you is something I am very interested in integrative and collaborative care. And I want to know what models that you have seen in your experience that have been successful that we can replicate and implement in especially rural areas that need more access.
Okay, so there are different models of care that I find are very effective. And a lot of them have to do is when you implement and integrate substance use disorder training and management inside primary care settings, OBGYN, emergency room settings, and just anything that's family medicine. So internal medicine, family medicine, OBGYN, anything that's high use, high resource, right? And at times you might have someone who's trained in that area who works in those clinic settings, or you might have someone who have a really good referral source in that. We call this thing like a warm handoff sometimes in medicine, where you would have a provider meet with a mental health professional and engage them in substance use disorder treatment and kind of walk them over to the PCP and say, hey, this person needs help with high blood pressure and diabetes. I'm also addressing a substance use disorder. Can we do a thing? Can we work together? Those models are highly effective. They're even effective when you have telemedicine working in those rural settings, in the primary care settings, and just implementing substance use disorders treatment that way. So, for example, someone might be waiting for their PCP appointment and then they're able to attend group therapy over telemedicine in front of that department, right? So, the models that work best are integrative care because then there's less stigma. People see a substance use disorders as a medical disorder, right? Not just something someone can't overcome. And then you tend to have so much more support, so much more resources. Because if you have a social worker involved, if you have a case manager involved, if you have a family care provider involved, Man, that's so much support for our people with substance use disorders.
Amazing. And I think with some of the studies that I have looked into, integrative care has come up the most as one of the most effective. So, one of our episodes also be highlighting xylazine treatment and how integrative models have played a huge role in that. So, be on the lookout. This is
Oh,
amazing.
I can't.
It's so exciting to have all of these. So, we have one more question, and then we're going to move into our next segment to discuss a case where we're going to practice treating someone that may come in. But our last question is, what is one change a small clinic or practice could make today to reduce barriers to treatment?
Okay, to me, the simple thing is screening for substance use disorders. That is easy to do. You can do it with the NIAAA question, the one question. In the past year, how many times have you used illicit systems or prescription medicine without the doctor's recommendation? Or in the past week, how many times have you drank alcohol? And in the past, and in a day, how many drinks would you have a day? Those simple screening tools is so effective and can open room for conversations. So I would say screening, because screening can be done by MAs, by nurses, PAs, medical students, anyone. It's free, it's easy. And for providers, there's a billable code.
Oh, look at that. So that's a little pro for all the providers. That's no, it's just taking too much time. You can actually bill for that.
Yeah.
So perfect. Well, thank you so much for the pros that you've given us so far. So, for our next segment, we're going to discuss a case. And this is John, who is a 37-year-old man. He was recently discharged from a hospital after surviving an overdose. He's motivated to start treatment, which we love, but has no insurance, no primary care doctor, and is very unfamiliar with buprenorphine. He visits a local community clinic, but is told that he needs an appointment with 2 weeks out to see the waived provider. In the meantime, he relapses. So, what do you think went wrong in this case?
Man, and unfortunately, we hear this story all too often. So the things I see that go wrong in this case is number one, why is John giving him a prescription for a month of buprenorphine if he's interested in as soon as he's in the hospital as he's released? You don't necessarily need to see a provider and be established for them to have the medication. Number two, why is that waiting list so long? Or what happened to our providers? Why can't he be seen by his primary care provider or his peer or NP? Because most people, if you're discharged from a hospital, you're supposed to be set up within 7 days to see a provider. And unfortunately, for the new bill, anyone can now prescribe buprenorphine. You just need to have your own DEA. So that's another problem. That's a big barrier to care, that lengthy wait time. Next, what about pair recovery? In most hospital systems and ERs, and especially ours, if you're screened for substance use disorder, he came in with an overdose. You have a pair recovery coach who can be calling him, talking to him every day, getting him set up with the meetings, and giving him that assistance he needs, and be an advocate for him. So those are some of the things I see that we could have done differently in that situation.
Definitely. I think it's important to try to shorten that wait times. And you made mention of why don't we give him buprenorphine for a month? But this brings us to the question, the providers sometimes feel very uncomfortable. They feel like they do not have the knowledge. So, if you would please, with your expertise, give us a quick crash course. If you were to teach someone in 3 easy steps of what to do and how to start buprenorphine, what would you tell them?
Okay, so I would say, first of all, ask the patient, when does your body go into withdrawal? Everyone who uses narcotic medications or use fentanyl heroin knows their warning signs. And then I usually tell the patient, I want you to start this medicine when you're pooping and diarrhea, you have a restless legs, and you're very mad. Don't start it before because you're going to get worsening withdrawal. I like to implement microdosing as an outpatient, right? So instead of giving 4 to 8 milligrams one time, I'm like, take a quarter strip, wait 3, 4 hours, see how you do. You did okay, take some more and do it that way. Fortunately, maybe unfortunately, most of our patients already have experience with buprenorphine or Suboxone from the streets. I have not met any patient in the past 2 years who have not tried one from the streets from their friends, so they're familiar with it. Providers shouldn't be as concerned because guess what? It doesn't activate the KRAS system. It's not going to cause significant respiratory depression as long as there's no benzodiazepine on board. So I'd say, please, you're saving lives. Give buprenorphine, okay? I know some providers say, well, what if they sell it? And I say, what if they sell it? You're saving a life. Who are they going to sell it to? They're going to prevent an overdose. They're going to prevent significant withdrawal of someone else. Okay. So while we don't like our patients to misuse medications, that shouldn't be something that stops us from providing help.
Yeah. And I completely agree with you, right? So the goal is to provide help. The goal is to save lives. That's what the oath that we took as providers. And if you missed what Dr. Bowe just told us, here are three things that I picked from what she said. The first thing is you, as the doctor, need to know the signs of what an opioid overdose looks like or toxicity looks like. And you should be able to educate the patient on this. So the first thing that you have to ask is, what are your warning signs? Ask the person. How does your body feel like, right? That's the first thing. And once you ask them that, you can then teach them what the signs are and tell them to take the buprenorphine once the signs start, because you do not want to precipitate a withdrawal that will happen if they take it before they're already experiencing the signs. So if you don't know what the opioid withdrawal signs are, I would have a CALS linked on the website somewhere in the podcast so you can look at it, or use MedCalc. It's on there. All you have to do is look at it and click through it. So all these resources are there for you. The other thing I picked up, and I have also learned over the years, is always start slow and taper low, titrate low, and that's what microdosing is. Instead of giving a huge dose, you can start lower and give it to the person. Also, the biggest takeaway from all of this I got, because sometimes we're all scared. That's why we're not prescribing them. But that one major thing you have to be aware of is if there's a benzo on board. So if the person has a comorbid, let's say benzo use disorder, you have to be aware of that or advise the person, please do not take this with a benzo. Please do not give it to someone that's misusing benzos. So all of this would be available. We will write all of this up in a very nice summary on the website as well for you all. So, one last question on this case. What low barrier intervention might have helped?
Low barrier intervention might have helped a prescription, a 1 week prescription, and then pair recovery to follow up and get them into the clinic.
When you say peer recovery, can you give us a little bit of an overview of what that may look like for those of
Oh,
us that do not know?
okay, so peer recovery coaches are people who are in a remission of their substance use disorder. Perhaps they used to use fentanyl or alcohol, anything like that. They work in ERs, and what they do, they meet patients. They talk to them about where they are. They assess their state of change, and they let them know, here, this is my number, this is my resource. I can get you into treatment if you need. And they give them the I guess the encouragement and the resources we need to make that next step. They also call you when you're done, and they kind of bug you if you allow them, if you give them your number. Okay. And see, because they've been there, they know how hard it is to take that step once you've left the emergency room. And they're just there to help and encourage.
Thank you so much. We've learned so much from you today. I want to give you the opportunity to tell us like one or two pearls that you would like to leave with us. Any key insights or any recaps that you like to teach today?
Okay. I guess I would say, as providers, as medical students, nurses, PAs, physicians, we have to love and care for our patients. And those who have substance use disorders are often shunned by their family members, their friends. They don't have a support network. We are it for a lot of people. So when you encounter persons with substance use disorders, kindness and compassion is the most important thing. You want that patient to feel that you care and that you connect with them. I would say that's my pearl.
Thank you. That is important. Compassion, leading with kindness is always advised. And if you have any work, any projects, any shout outs you would like to give, please use this time.
Okay. So I would like to give a shout out to CAMC, Ashley Murphy, Lahoma Wilson, and our recovery coaches. You guys are doing an amazing job. Huge shout out to Triple AP and all the amazing work you've been doing with addictions throughout our nation. Huge shout out to the ORN. Huge shout out to Ayana Jordan and her work with Reach through NYU and Yale. You guys are amazing. I'm so happy to be a part of this team. Thank you, Dr. O, for letting me be here today.
Thank you, thank you, thank you. And I am second in all. I don't even think that's a word, but I second all of these shout outs. especially to Dr. Ayana Jordan, because we have her coming on an episode to discuss.
It's amazing. Okay, yes, I'm pudding. I'm so happy you have her coming.
Yes, we love her. We love her. So a huge shout out to Dr. Ayana. Look out for her episode as well. Listen to it if you miss it. And we would like to say a huge thank you to Dr. Bowe. We know you're very busy and taking the time to come on here to teach us a few things about how to accurately and how to, bridge these gaps that we have in our system as providers. So thank you so much. We appreciate you. And thank you all for listening to this episode. And my personal shout out goes to the NIH and NIDA for funding this project, and to the NMA, the National Medical Association, for also sponsoring this. I am very grateful. And to my mentor, Dr. Hurston, for mentoring me and guiding me through this project. Thank you all so much for coming.